One moment.
Yeah, just give me thumbs up when to start.
Yeah, okay.
Okay, thank you, Sabina. Welcome to the online conversation on the situation right now we have in India, and our conversation titled COVID SOS, India to the World. And really, it is an SOS to the world, not only what's happening in India, but what's to come for the rest of the world. My name is Dr. Vineeta Gupta. I am a director of this Action Secretariat, a global health advocacy partnership. It consists of 15 locally based civil society organizations across 5 continents. Most of our partners do grassroots advocacy, engage volunteers. So we'll be talking more about that. I'm also a maternal and child health physician and a human rights lawyer with my own roots in India. So today's topic hits home for me. As Indian diaspora, we carry the weight of painful stories of human suffering coming out of India. And I volunteer with India COVID SOS, leading its policy advocacy effort, a group of passionate volunteers who are working day and night to make a difference in India, neighboring countries, and elsewhere. Today, I have the honor of chairing this session, hosted by Action in partnership with Results Education Fund, a grassroots organization, advocacy organization based here in Washington, D.C., and with chapters all over the U.S., and India COVID SOS, as I mentioned, a diaspora 100% volunteer effort. To learn more about the organizations, please see the organizational websites that are being posted on the right side of your screen in the chat box. Before we get started on the discussion, I want to run through a few logistics on this event platform. We want to hear from you on this conversation. And please share your thoughts and your questions for the panelists, for each other, through the chat box that's on the right side, as I mentioned before. And we will be monitoring the messages. We'll try to pick up some questions at the end and have a more, if the panelists answer your questions. We will also be live tweeting and retweeting and sharing your tweets. So please do that. Do engage with us on the social media, and we will be putting the panelists and their organizational Twitter handle in the chat. Feel free to share yours as well. This conversation is what we all make of it. So please participate actively. This event is being recorded, as you saw when you got on the event. The recording will be shared with everybody who signed up, and plus it will be available online on our website, action.org. And it's also live streamed. This event is also being live streamed on YouTube. So thank you. I want to thank you all for your engagement, for whatever work you are doing to make this a world a better place, whether it's focused towards India or the other hotspots or in your life elsewhere. The main objective of the sessions are get to know the status in India. We have great panelists, what India needs and what global community, and each one of us in our own level can contribute positively towards the situation. And also I want to say one thing that sometimes I personally think too, and people ask me that question in the workshops. It's okay for us to define our own limitation, own contributions, how much we can do to the best of our capacity. Everything matters. So please don't hesitate if you have 1 minute to offer, an hour to offer, or you can do more. Whatever works for you is useful. And so we will talk about a situation in India. We'll hear from US policy experts, and then we'll also hear from the global and the African experts to talk about how we can all contribute positively to this situation. You can help support the global effort, and we'll be sharing all the resources on the side as well as we go along. Without further delay, let me introduce our panelist. Professor Dr. J.A. Jayalal, National President of the Indian Medical Association. You can see his profile links in the side on the chat to learn more about him. And his Twitter handle is on the slide you see, and please feel free to engage. Our next panelist will be Dr. Kavita Patel, a non-resident fellow at Brookings Institution in Economic Studies for the USC Brookings Institute Initiative for Health Policy in the US. And many of you might see her on MSNBC as an expert. Ms. Rosemary Mburu, the Executive Director of the WACI Health and Africa Regional Civil Society Organization based in Nairobi, Kenya. And she's also an action partner. We'll start with Dr. Jayalal. Dr. Jayalal, I want to start with the first question. Where are we on the COVID-19 in India right now? Could you please share the situation from the ground? And as you had this biggest organization of physicians in India as the national president of IMA, Indian Medical Association.
Yeah, thank you for the wonderful initiative which we have taken and the lot of good works you are doing. I'm really thankful for you as an Indian resident in NRA, settled there and doing a lot of innovative work. And thanks to all my panelists and the people who are with me at this moment. I'm reporting from India. I'm sure that at this moment, the Indian healthcare system and the amount of people whom we are having for the treatment is enormous. Every day we are getting many more people are coming to the hospital with a sickness. And we are seeing a lot of difference in the cases, which we are seeing in the first wave and the second wave here. Many people of the younger age group are coming in. The people are coming with a lot of severe disease than what we are in the earlier part. We saw a lot of people with a mild disease. And a lot of people are still coming to the hospital with an acute respiratory distress and acute condition. And the deaths are also more in the hospital setup. We know the population of the India, which is nearly 1.4 billion. And there's so much of population and so much of congested areas. The spread of the virus is happening very quickly. And the infectivity rate, what we are having today, and the test positivity is nearly 25%. That means almost 1/4 of the person who is coming here and doing the testing are getting positive. I sense it is a communal spread, so it is spreading very, very fastly. We are trying our level best to cope up with the situation with rapidly increasing the hospital beds, rapidly increasing the resources what we have, and rapidly increasing the manpower of the hospitals. In spite of the difficulty we are facing in the shortage of the manpower, shortage of the beds, the fatality rate is remain low because of the committed work of the doctors and the healthcare workers of this country. Though we have lost many doctors in the forefront who are working for the country, but still we are working hard in this situation and we are able to save thousands of people from the clutches of death. And today the mortality still remains as a 1%, which is much lower than most of the other parts what we are seeing today. And now the government has infused in one of the area which we heard as an oxygen deficiency, which has been now improving. A lot of oxygen generators were installed in the particular states. There are a lot of oxygen which was used for the industrialized use. Majority of the oxygens were using for the industrialized use. Now all of them are converted to use for the oxygen for the hospital use. Remdesivir, there was a lot of hiccup we had, when to use, when not to use. Initially, there was a rampant use. Now we had started a lot of social awareness for the doctors also, and right, appropriate and judicial use of remdesivir has been happening there. The death which is happening is something more than what we expected, but the situation is grim. But manpower, all the stakeholders of the country are working hard to overcome this pandemic. I know there are various reasons for that, but still at this particular point, our concern, our aim focus is safeguarding the people who are coming in a difficult situation to the hospital and getting over this pandemic as early as possible so that our country will be reopened for the people to move forward.
Thank you so much, Dr. Jayalal, for sharing with us the grim situation that we have. And viewers, please, listeners, please do engage and share your own thoughts and statuses from India through the social media Twitter handle, either using the handles of the organizations or the speakers. So you mentioned how stretched our workforces, right? We already had a stretched workforce, whether they were ASHA workers or the physicians. We know that we were in India already stretched. What do you think are the crucial, like top needs of the workforce that could help them at this juncture when there's a onslaught of from all sides? The existing health crisis, and then on top of it, this horrific COVID-19 crisis.
Yeah, absolutely true. But you must always remember India is one country where the population is so much. But in spite of that, that is a healthcare system, the infrastructure is even percolated to the most of the remote areas in many of the part of the country. There are certain areas, yes, it is in the lot of areas in the North India, in some of the states, where there is a healthcare need is not reached to the remote corners. But if you see many of the south and central areas and most of the areas, cannot be pointed out in a single part where there's a doctor is not there or the infrastructure bed is not there. So what we see, there is a swift reactions from the government to convert a lot of centers, including the railways, the railway coaches into an hospital beds, has helped us to get the rise over the infrastructure facility for the beds. As you rightly said, one of the still the difficult area what we are facing is the manpower. It is a manpower we were able to support this cause by extending our working hours. Normally, when the doctor is working for 8 hours, now most of the areas they are working and 1 or 2 hours extra. And second is a multitasking. But initially we had the staff which are designated for a particular work. But now we have made our staffs to work in a multitasking, and somebody will be working, helping us in the taking the vitals. Somebody will be helping the, even taking the investigation. Somebody will be taking care of the personal care. So the people are willingly coming forward and doing the multitasking, and that is helping us to sustain the manpower in the hospital. And the third, that manpower is the government has now started and incorporated the final year medical students, the medical students who are still on the education but doing their MBB undergraduation, who were in the final year, they were asked to come and report to the hospital and work in the hospital. That means we have nearly 85,000 people are doing in medical education every year. So this large chunk of people now coming to the hospital to help support the doctors. But you know for sure that they are not competent enough to face the crisis situation, but they are only helping us in the auxiliary work and the work is needed whenever you're doing the work. So the manpower shortage is there, and the people who are working is also a lot of stretched out. They are doing a lot of multitasking work. So that is one need which we definitely we have at the present is a manpower. But we must also realize, and it cannot be produced all of a sudden, and it is a long process. The government or anyone who is involved in that cannot just produce a doctors and who is qualified to come back and work in the hospital institution. This is a long felt need. I'm sure the government will understand this in this critical moment, and they will start initiate the process so that the trained and the qualified manpower will be increasing in the hospital. So that is one of the major challenge we face. And as you asked, and what are the needs the hospital, the doctors or the hospitals is facing? Yes, at this moment, and we face a little shortage of oxygen and remdesivir is there. But at present, and as on date today, we have got millions of oxygen generators has come in. A lot of PSA units, the self-made oxygen generator unit has been established in the hospitals. All our other works are stopped. That means entire hospital infrastructure, entire hospital force is now diverted or focused only to the COVID care. So that means almost all our elective surgeries are cancelled. All our other areas where we need to spend the oxygens were being spent. So we are now, entire our limited infrastructure, oxygen we are able to use for the people. But it is still an open, there is a lot of many foreign countries that send the oxygen concentrators to India. We still need more, and we will definitely welcome more, and whatever we get the supply of the oxygen, definitely it is a great support for the India. But drugs wise, now India has enhanced the production of the remdesivir in India. Most of the drugs are available. One of the other now issue we are facing with the black fungus or the mycorrhizasis, that is, we are getting a few cases of mycorrhizasis in the cases. So we need to have some of the drugs to tackle that condition also. So Indian government is taking steps to produce these drugs indigenously. But what oxygen will still need a lot of work to do. Another major concern where we are going to concentrate is on the vaccination, because we know for sure the vaccination is the only tool we are having to overcome this pandemic. And we are trying our level best to enhance the vaccination at this situation. As on date, 180 million people of our country has been vaccinated. But the target for us is 900 million people has to be vaccinated. Those who are the people who are above the age of 18. Although we have the population of 1.4, now we are focusing only for the patients who are, people who are above the age of 18. So that comes to 900 million. So there's a long way for us to go further to reach out to the level that we will be able to vaccinate all these people. But we are setting a target that at least before this year end, all our people should be vaccinated. We have some issues with the vaccine production. Now, most of the foreign vaccines are also getting clearance from India. We have already given clearance to the Sputnik, and Johnson & Johnson vaccine is also on the trial. So we will be expecting from the next 2 months, we will be able to get more vaccines in the forefront. And the ramp up of the production of the indigenous vaccines, both the Covishield and the Covaxin, are also taking place. Now the government has assured that at the end of the month or the next month, we will have nearly 300 million vaccine can be produced indigenously. Now that is a good step. But what we need at this moment, so all this vaccine can go only with the pricing, because the government is trying to put 50% of the vaccine free and the 50% vaccine in the open market. So, but still we will be needing a lot of support for this mass vaccination. So Indian Medical Association has taken a project of 1 million vaccination drive with a free of cost to the people who are in need. So we need to buy this vaccine, and we are trying to make the infrastructure available with Indian Medical Association doctors, and they are going to voluntarily supply this vaccination to Indian people. So it will be our appeal to all the people to extend your support in the mass vaccination project, because that is a long-term project which we are going to do, which will be able to help our country to get rid of the pandemic and have a sustainable, free environment in this country.
Thank you. Thank you for sharing in detail the needs of the health workforce as well as the other needs. I think that you address my thoughts were like, what can global community do? So you already addressed some of those factors on what global community can do, either at a personal level or advocating for their governments. So I want to highlight three things. Everything Dr. Jayalal said, please do engage with it. Again, I encourage viewers through social media. But three things I want to highlight. One is the collateral damage that's happening. Everybody's focused on COVID-19, rightly so, but there's a collateral damage that's happening, and hopefully we'll talk through our conversations more focused on what that collateral damage is. But elective surgeries, maternal and child health, right? There's a nutrition pandemic that's happening on the side. Midday meals are being reduced because of the lockdowns that are happening. You saw some of the slides earlier. So I want to highlight that. Second, I want to highlight is the help from Action Partnership is working tirelessly day and night on mobilizing the resources from multilaterals and donor countries to put in more, whether it's a Global Fund, whether it's World Bank, whether it's Gavi for COVAX. So we are working tirelessly to increase the funding and also release the funding that's already allocated. And the third thing I would highlight is for our audience is that you can explore our partnerships, 15 member partnership in every country, and see if you can engage. And the India COVID SOS, we are addressing many of the things that Dr. Jayalal mentioned. For example, our volunteers are working so hard. I cannot tell you, our volunteers are on the calls until midnight talking about, listening to what Indian needs are. And they're working on developing training materials for the health workforce that Dr. Jayalal just mentioned. And also commodities, scrambling with like on the phones, on the WhatsApp, who needs where. So please feel free to engage on both. It's indiacovidsos.org or action.org and then you can scroll through our partners in your country and you can engage with them. So I want to make those points before I move on to the last question, Dr. Jayalal. Any other thoughts that you want to share with our audience today? Any other thoughts on the broader
Today
perspective?
we are living in an era where the geographical boundaries has lost. The corona has made us all one family. I think whatever the difference we had, whatever no country could boast that with that infrastructure, with my intellectual, with my lot of manpower, lot of wealth, we were above corona. Corona has made an equalizer. So this is a challenge for the entire our global community. And every time we are getting a lot of pandemics. Pandemics are doing havoc. But this pandemic is for more than 1.5 years. It is producing a very challenging issue. And but I feel as a doctor who has been in the medical field for 30 years, I feel ashamed that I'm not able to come out with some good solution where it can give a very positive result for that challenges like this. So it is a big challenge for the global community, where we need to find out about something like this is happening. So much of people are suffering and the lives are lost like anything. And what we can do, we talk so much about our medical profession, so much about this modern medicine, but still we are finding it, and every day we are learning. And one day we are saying a particular drug is useful, and second day we are saying that is totally not used. Plasma therapy we said and useful, and now we are saying WHO has removed the plasma therapy. So a lot of confusion is taking place. But why this way not have we had a rich experience, so much of case study, so much of knowledge input. Why we make the WHO or the global form where we will be able to come out with an uniform or the very, very sustainable results and evidence-based results to tackle the situation. Yes, it is a difficult situation, but what the research area, we need to still more further focus, not only level at the molecular level, but we need to expand it in the a larger level of economic concern, our financial condition, even to the extent of Dr. Vineeta's specialty area of the human rights, legal, and what is happening at this moment. And or we say that it's a ethical concern of an autonomy and the responsibility of the society. So these big challenges, I don't think that we should focus in a small regional or a country level, but this is a good concept. I like it very much because you are taking much of the countries where you are able to discuss together, and this should come as right from our depth of our heart, and what we are going to do for this corona pandemic. I'm sure still countries has to suffer for another 3-4 months, or I am not sure that how long we are going to be with the corona. But what is our response as a learned colleague, a learned community, scientific knowledge people? Something more we need to come out and support these countries to overcome this corona pandemic.
Thank you, Dr. Jayalal. And it's very right that pandemic preparedness, why do we get to this place over and over again, right? We dealt with the tuberculosis, we dealt with the HIV AIDS. So COVID-19 pandemic has further exposed already existing deep social and structural inequities between the countries, from the donor countries and implementing high income countries and low and middle income countries, and also within the countries who can access the best of the care available. The impact of the pandemic and inadequate response has been widespread and devastating for socioeconomic well-being, essential health services, including routine immunization, basic nutrition needs of the children. By 2020, an estimated 2.6 million children will be stunted. 2.1 million mothers will be anemic. 168,000 children will die if we don't act right now, right? It's already late, but we need to act now and to fill the gaps in funding for pledging, for example, Nutrition for Growth Summit or with the IDA replenishment. So we need to act right now. You're absolutely right, Dr. Jayalal, that we need to think ahead and get ahead of the curve next time and also mount our response now. Now I'm going to talk to Dr. And it's also a good segue into getting to the US policy issues, right? US is a big player in global health. And we'll go to Dr. Kavita Patel to talk about US policy. So Dr. Patel, in the US, we are heading towards more of a normal summer. in the circumstances what a normal summer can be here. What do you think are the implications domestically in the US here, and also for India and other low income and middle income countries around the world? What's the implication for that?
Yeah, so thank you for having me. And I think I'll direct my background is much more domestic policy in the US, but in terms of pandemics, I've been part of kind of working with ministries of health and other governments and trying to understand how can they learn from what we have learned in the United States. And I'll say three things are kind of very clear. And I wanted to take a chance because some of the viewers are clinical in the audience and talking about what we learned a little too late. We saw this initial set of waves, and then we realized that there were sequelae clinically. One kind of very important clinical sequelae is in children. It's an inflammatory syndrome, MIS-C, in children. There's also this black fungus that I think has been also documented in India, which is also determined to kind of be possibly not a separate disease, but something related to COVID. And I think what we learned in the United States, which is something that I think the governments should somehow work together on, is creating an information structure that can allow for this type of understanding of the clinical disease in a better setting. And I'll just give you a very practical example. Dr. Jayalal talked about remdesivir. We were using remdesivir like crazy initially. I was trying to secure remdesivir when it was under trial. And then as soon as it got an emergency authorization, was trying desperately to get it. We are now seeing more and more studies where remdesivir might be helpful in very particular cases, but I would say overall is actually not that helpful. And let me use another example of a drug that we never even kind of bothered to use in the United States, ivermectin. Also another drug that I think has been, and I'm going to use a term, and I'm not trying to be negative about it, I'll say exploited, because people outside the clinical worlds in India, my own relatives, most of whom are in Ahmedabad, some of whom are medical, have kind of said, how should we use ivermectin? And they'll send kind of a list of the things they're using. And I've said to them, I know that it feels like doing something is better than doing nothing. But in the United States, with a lot of experience through 4 surges, we've learned kind of what we should have known in the beginning and really prevented. We probably could prevent more harm by using the right kind of formulas and medications, and also giving instructions. Dr. Jayalal's point about kind of health professionals, we really did need to learn in the United States how to go what we call upstream to lay people, so that family members could understand what to look for and determine who needs to truly come to hospital. Because I think when you're scared, the instinct is, let me take my bapuji and let me bring him to a hospital. And waiting and trying to secure a bed can do more harm than following some basic measures. So Vineeta, I'll just say, number one, it's been interesting. How can the United States government translate some of our clinical learnings and provide that technical support when necessary, not just to health professionals in India and to IMA and others? And it's not because the IMA professionals are not smart. It's just we've had 4 surges and we've learned kind of a lot through them. But also, how can we then prevent, I think, what's happening where some people are being exploited kind of and paying lots and lots. I mean, people are paying incredible amounts of money. Their entire savings, if they have any, are being depleted so that they can get access to treatments that just frankly don't work. But then third, I do think the United States government, and Vineeta and another physician colleague wrote a piece about, everybody's focusing on vaccines. Dr. Jayalal made a point that the vaccination program is incredibly important. The United States government is not going to give 1.1 billion vaccines. We don't have it. What we can do is really provide kind of the force of the G20 and other developed countries to think about domestic manufacturing capacity. And once we've vaccinated the majority of our country, which we're getting closer to doing, as we return to normal, we cannot let our guard down, because as Dr. Jayalal, Vineeta, you've said it, we've all said it, Corona knows no boundaries. So if we don't deal with India, and I think Dr. Mburu is going to talk about, I personally worry about Africa. If you look at the healthcare capacity in some of the countries in Africa, their ventilator capacity and healthcare professional capacity is much lower than other countries. And there's no reason not to believe that it couldn't face their own surge it's been experiencing surges. So we've articulated for the United States government, one, using its domestic manufacturing and leveraging it with other G20 countries, even the G7, and leveraging manufacturing as these countries have higher vaccination rates. Number two, really translating our learnings to prevent kind of the, I'll call it the inappropriate use of not just medications, but treatment settings. We've also learned a lot in India, in the United States about hospital at home. So I've been working with some physicians on the ground in Bangalore who really have no capacity while the government is trying to build beds and build hospitals. We've been trying to teach them how we've been doing kind of a hospital-based level of care in the home setting, and that is possible. In India is, in my opinion, the global technology giant. We depend on India technology in the United States. It's time now to kind of reverse and be able to leverage kind of the IIT and the genius that's there, but for the care they need in the country. The third is accountability and transparency. We saw in our own country the deficits when we had states that did not have transparency in their reporting of COVID cases. And it led us in the United States to take actions without all the information. We cannot get political about this. It's just facts and data, but we need to ask that even if the story is a bad one, even if it means that, and I'm going to use my own hometown of Ahmedabad, even if it means that and I'm using this as an example, even if it means in that Ahmedabad that there's been some terrible outbreak and it was accelerated because of poor management of infections in a hospital, we need to understand that. And we had those examples in the United States, and it was only after we asked for our CDC, our federal agencies, to have a transparent data requirement that we understood that. India has a lot of these kind of data registries, databases, again, technology that is unparalleled in the world, but we need to have accountability and transparency so that we learn from it. What I can say is that my fear about India, and Vineeta, I'll stop because I think people are this is a very deep topic. I'm grateful that given the time zone difference that we've got so many of us globally listening, I would just say that I worry that India can't get a vaccination program executed. Just physically, there's not enough vaccines to avoid its third surge. So my kind of planning isn't just for, there's a conversation in the United States that's becoming very popular. Cases are peaking. They are, they appear to be decreasing. We would expect this to happen. It's what happened in the United States. But then we experienced almost to the calendar, kind of 2 to 3 months later, our own surges. Now, could India vaccinate the majority of its population, or could the majority have been infected and then get vaccinated? It's possible. And that's hopefully, I think Dr. Jayalal's point, that's the goal. But we would be really, really, really irresponsible if we in the United States did not do everything we could to make sure that any third surge, even a small one in part of the country, could not be prevented. So I'll stop there and I'll just say I am very proud of the diaspora and the response. It's still going on. We still have United States kind of first generation, second generation Indian Americans who are, collecting PPE and doing what little they can in their own capacity. And I think it's just a great reminder that this is one world. And I do want to say this, I've gotten criticism, social media and publicly, for not drawing attention to other countries where cases might be higher per capita, Latin America, other parts of Asia. I completely agree that I think we need to remember we're talking about India just because of the focus of this conversation. Everything I just told you, I could transfer and fill in another country, Latin America, not just Brazil. We're watching rates in El Salvador. We're watching rates in Guatemala, Mexico. These lessons are broad. This has nothing to do with one country versus the other. And so everything I said, transparency and data, accountability, lessons about what clinically is working, incredibly important. And then the final is kind of, children. Pediatric cases, children got minimized in the United States because they're just not as severe. But none of us I have children, none of us want to lock our children into a future that could be less than what it should be. And I think the same could be said for any other country. And so we do need, in the United States, we joke, in policy, we talk about how children can't vote, so they often don't get a voice. And I think the same could be true across the world. You know, we all kind of need to remind ourselves about populations that just aren't going to have a voice. So hopefully, so anyway, thank you for everyone, and just incredibly impressed, Vineeta, with the work that the panel is doing, and hopefully can be a part of it.
Thank you so much, Kavita. And as you are doing such amazing work, I just want to mention that Dr. Kavita Patel served in the Obama administration as Director of Policy for Office of Intergovernmental Affairs and Public Engagement in the White House. So she has in-depth knowledge of how we intersect in the US and the globally with other countries. So we are really privileged to hear your thoughts on it. Any thoughts that you want to add, either like you mentioned already, but any additional thoughts you want to add on how India can learn from you know, the data modeling that happened in US, or what people can do in general? Any thoughts, broad ranging, additional to what you
just the final thing, because there's a sutra, Dr. Jayalal probably is very familiar with kind of the sutra model of what, you know, India is trying to follow. It's a just for people who don't know, it's a mathematical model that's taken into account a number of variables to try to kind of illustrate when cases would decrease. And I think it projects, Dr. Jayalal can correct me, but it does project that cases are decreasing and that they will kind of come down, right? I think he's nodding, so I think he agrees. I would just say that we had our own models in the United States, and we learned as we were going through various surges that, you know, you have to have a little bit of forgiveness in these models, because we couldn't really model the variants. We couldn't really model, you know, when travel opened back up, we couldn't really model, you know, the UK variant. We couldn't really understand what we didn't know. And that's why I bring up the point that for the United States, we have an obligation, not because, you know, we're better than anybody, but we have an obligation that we were first in line to get these vaccines, and we got them. And we're still trying to get our country vaccinated. But now we have I feel like a moral, ethical, and candidly, just a worldwide obligation to make sure that we export our learnings along with exporting our vaccines. And I think that's what we've called on the Biden administration to do. I have an incredible amount of confidence in the USAID administrator, Samantha Power. The people that President Biden has kind of leading these teams are incredible. I just don't want them to waste time, because we don't have the luxury of time. India could be going through a third surge while it's trying to execute this very ambitious vaccination program.
Thank you so much, Kavita. And we'll move to Rosemary now. Rosemary is, like I mentioned before, WACI Health is action partner. And my question to you, Rosemary, is what lessons should African countries take from India's experience? You know, what we have been going through in India and US also, and how can they be prepared for the response to COVID-19 pandemic?
Yeah, thank you so much, Vineeta, and it's a pleasure and an honor to be on the panel. And it really is a privilege to be speaking about a topic that has actually taken so many lives. And so it really is a privilege to be here to even have the opportunity to have this conversation. We do know that the onset of COVID-19 has demonstrated the challenge of inclusion. We are seeing a lot of inequities. It has exposed a lot of inequalities, including highlighting inadequate social protection systems, deepening of pre-existing inequalities among, being faced by women and girls, especially in our region, et cetera, et cetera. And so I think for me, the first lesson we have learned, not just from India, but I think from the pandemic itself, is that the conversation around preparedness and response at this particular moment needs to be expanded to go beyond the preparedness and response in terms of global health security, but to actually focus on global solidarity and health equity. One of the biggest lessons that I think Africa is learning from India, or should learn from India, is that we need a comprehensive response to the pandemic. Early on at the onset of vaccine development and delivery, a lot of African countries actually focus on how can we get the vaccine. Of course, we know we are only getting 2% of what is right now out there as Africa. But I know we have also been thinking a lot and putting a lot of effort and thinking and I guess relying on the availability of a vaccine when that does happen. But what we are learning is that we need to think we need to also think about the non-vaccine commodities. We need to think about oxygen. We need to think about rapid diagnostic tests. We need to think about PPEs. We need to think about all the different commodities that are needed for us to be able to respond to the pandemic. And not just the therapeutics, the diagnostics, the vaccine, et cetera. We also need to think about and to remember that no global health response will be successful without communities. And at a time when the healthcare workforce is so stretched and so fragile, we need to learn lessons around community health workers who are going door to door, who are actually delivering the commodities, who are sort of ensuring that there's progress. And when people cannot reach to the hospital at the community level, that's our best bet in terms of getting care. And so we need to think about how we invest in our health systems, and not just the health systems that ensure medical availability of commodities, etc., but also the community systems that then ensure that we sustain a response and that our response reaches to areas where actually the health system itself cannot reach. So equipping community health workers, equipping even community groups, ensuring that we can participate even in monitoring and accountability, etc., etc. One of the things I guess we have learned is that we have to think very strongly about the fact that COVID-19 has affected other sectors beyond health, and it has mentioned here. And what we are learning from India, for example, around, just pushing more people into hunger, where children actually cannot access food with nutrition value, etc. We need to think about nutrition. We need to think about the other elements and components that are important in terms of ensuring that as we respond to COVID-19, we are thinking about the other sectors, like food, like children wasting away is actually an epidemic in itself. How do we ensure that we actually address that? I think the other thing is, in all this, you learn that there are many ways to strengthen health systems, but I think using primary healthcare as an entry point is something that we are learning. We need to strengthen primary healthcare systems right from the community level all the way to the national level. Thinking about how do we do routine immunization, for example, at the lowest level of community health facility. How do we ensure that the maternal, newborn, and child health services are not disadvantaged? We saw a lot of diversion here in Kenya when COVID-19 just happened, and a lot of resources, human resources and financial resources were diverted. And so how do we ensure that we are not responding to one pandemic while the other epidemics like HIV, TB, malaria that have really weakened our health systems continue to kill the same lives that we are trying to protect? So I think it's mainly around ensuring there is equity. It's really about health systems. It's about community systems. It's about primary healthcare. It's about non-vaccine commodities and ensuring that we have that. In all this, there's a question of where is the money to do all this work? Where is the money? And so one of the lessons that we continue to learn, and not just from India, from even previous pandemics, is that we have to have stronger systems around domestic resources. We need to have stronger systems around how we generate, domestic revenue. It helps a lot because, as you can see at the moment, it's rich countries versus poor countries, in terms of access to vaccines, in terms of the response, et cetera, et cetera. How do we actually better prepare by ensuring that we put in mechanisms around domestic resource mobilization. So I'll keep it to that. I think there are many other lessons we are learning, but I did want to highlight those.
Thank you, Rosemary. And I know that you are engaged at the country level plus regional level in Africa and the global level with different mechanisms. Can you a little bit talk about what is being done there, how you're engaged and what can be done, what's the role of different mechanisms? Anywhere you want to go with that is very helpful to have the information.
Yeah, so I think I'll start with something that has been mentioned here on the call. Someone spoke about the World Bank kind of work and advocacy and IDA coming up in terms of replenishment and resourcing. And in Africa, we've been following on World Bank funding here to look at like, where is the money going? Is it going into like human capital investments? And that's an area of interest to say, how can we ensure that investments are going into things like education, health, social protection, nutrition, because then it goes a long way in terms of securing the human capital development of a particular region, especially here in Africa. So that's something that we want to see highlighted in IDA. We want to see African countries prioritizing human capital investments. So that's one of the things that we are advocating for and wanting to see. The other thing is around, like, we have an opportunity with the Global Fund coming up. The Global Fund was the first multilateral institution to respond in terms of COVID-19 response mechanism. And in terms of safeguarding the gains on HIV, TB, and malaria response, there has been a lot of support from the Global Fund side. But we also know that the Global Fund is coming up for another replenishment next year. And so that's also something that we are very keen to see how that will go in terms of ensuring that the Global Fund is supported, ensuring that the replenishment is sustainable, so that we can continue to safeguard around HIV, TB, and malaria impact that has so far been achieved through the Global Fund. There is a G20 also, is another area that's where we have been working, basically talking about, you know, how COVID-19 has exposed the weakness of health systems and social protection systems, and really calling the G20 leaders to think about equity, calling the G20 leaders to think about even encouraging around the intellectual property rights. You know, India and South Africa, you know, have this proposal, waiver proposal around IP. And you see G20 countries have for quite some time been blocking this. We celebrate, you know, the US for actually supporting the proposal, supporting the waiver. But we do know that there's a lot more that needs to be done in terms of tech transfer, ensuring that we support expansion of manufacturing capacity in Africa, et cetera, et cetera. So those are some of the things that we've been working on in terms of the key moments and in terms of the policy entry points for policy, advancing policy that can support preparedness, response, and ensuring that health equity is achieved.
Thank you, Rosemary. And I just want to highlight one point there also. You know how when there's a crisis, the global leaders sometimes, or the community, goes towards a new shiny thing. We know the mechanisms exist, whether it's a Global Fund or Gavi or whichever mechanisms that we have at the global level, multilaterals and bilaterals. There is a role for them to be more effective. There's a scope for them to be more effective, more resourced, more transparent. So it would be helpful. It would be helpful to look at them, where they worked and where they did not work, and make them more effective, resource them better, so that next time we are not faced with this. Instead of creating a parallel system and then working through it and down the lane, another pandemic, and realizing that mechanism needs fixing as well. So it's a circle of going into things without having effective structures, multilaterals that can spurt up a response, have the resources to do it, and have the transparency and accountability to, if they fail, to be held accountable. So thank you, Rosemary, for sharing all this. Any other thoughts that you have? Otherwise, we'll move to the questions that viewers have for the panel. Any other thoughts you want to add, Rosemary?
Yeah, just very quickly, because you've mentioned accountability, civil society, and communities. I think just to highlight that even within this pandemic, there's a huge role that civil society and community accountability and advocacy work comes to play. And one of the panelists had mentioned, like the lack of transparency in some of these processes where you are not very clear where the resources have been allocated, how it has been prioritized, et cetera. And so just strengthening that space for civil society and having governments actually meaningfully engage civil society, ensure that there's transparency, there's access to data, access to information is very important, because it strengthens civil society and community accountability work, which is very important in terms of impact on the investments that everybody is putting into this response.
Thank you so much. And I just want to remind viewers and our audience today that advocates like Rosemary are working hard so that Africa can take the important lessons from India and elsewhere, like Rosemary mentioned, and also they're learning to other countries. So we are a global community. So we are in this together. And we, as an international community, must step up and have collective power behind wherever the pandemic is, to respond to it and also to mitigate as we get ahead of the pandemic. And also I want to say about the equity, I want to reinforce what Rosemary mentioned, the primary healthcare, health system strengthening, and health equity, and some other very key points she made to emphasize on that. So I also want to invite the volunteers to either explore action, go to WACI Health website or COVID India SOS website and find the ways to engage with global community or whichever community they will function with and share. And I know that there are lots of questions in the chat today. We might not get to all of them, but please do take those questions to Twitter and share, and all of the audience also respond to each other to have a dialogue continued after this session as well. Now let's take one question, and it's to all the panelists. If we can go around and ask people very important question. How do we beat the misinformation? We dealt with in the US, we are dealing with it in India. We see the pictures that you saw in the slideshow also, the cow dung bathing that's been happening to prevent COVID-19 in India. So every country has its own set of misinformation. How do we beat it? What's the role of individual, civil society, and the countries? Take it away any way you want to the panelists. Kavita, we'll start with you.
I think, so I do think that the only way to beat misinformation is to have very clear kind of, I keep saying transparency, but very clear information broadly disseminated. Hemal in the chat was just asking, like, how can we create more of an international kind of clinical information sharing? As I suggested, the WHO, I mean, there are organizations that kind of lend themselves to it, but it doesn't seem to have happened yet. And I think it's because if you go to the UK Ministry of Health website, it says something just a little bit different than the United States CDC. If you go to India, kind of even down to the different state levels, there is just a little bit of differences. And so I do think that one way to battle the misinformation is to have some very kind of evidence-driven, accepted standards, even if countries and states and local governments can't meet those standards, that we all agree that, this does not work or this does work. And I'm just speaking, Vineeta, about clinical information. I also will tell you one of the most popular threads on social media from India a couple of weeks ago, WhatsApp actually, was that, if you're infected, you don't need to get vaccinated. And I think that's just, these are the kinds of things where I think the intentions are good, because the government has said that if you've been infected, you need to delay vaccination so that people who don't have the infection have access. Very correct. but it's confused by the public who is interpreting that as I was infected. I really never need to, I don't need to be vaccinated. And so we need to be very clear now worldwide. The message is clear. Vaccines are our way out of this pandemic, but next, clinical management, if you do get infected, what do you do if a household member is infected or a family member? And then guidance about what, I worry a lot also about the misinformation that's coming out, not just out of India, but out of many countries about, people's voices being suppressed or this or that. It doesn't need to be political. We just need to emphasize that data is going to drive our decision-making. Data is going to support what we state. And so wherever possible, one habit I've tried to create in the United States is like anything we say, we show the data to support it. And I think that should be something, Twitter is very easy to just do something and hit send. We need to kind of say, if ivermectin or I mentioned remdesivir, here's what we know about remdesivir and here are the studies. Let anybody link and then try to understand them and then communicate to the public in very plain language why we want to encourage isolation if someone is sick and that we shouldn't put them in a car and bring them unless certain conditions are met to come to the hospital.
Thank you, Kavita. We'll go to Rosemary next on the misinformation and then to Dr. Jayalal. How can the individual, government level and civil society can address the misinformation? Rosemary.
Yeah, I think there is an opportunity to learn from the HIV movement in this one. When we talk about the HIV treatment and what the movement, government, civil society, especially led by civil society and communities, did to ensure that there was treatment literacy, where all the way from the top to the down person at the village can actually articulate what medicine they are taking, what medicine is required, and what is HIV, etc., etc. And I think that's what has been missing, that kind of literacy that is community-led. We saw it working in HIV response, and I think it can work around COVID-19. But I think we are very slow as a global community to invest in community literacy and in community-led interventions, and I think that's something we are missing as a global community.
Thank you, Rosemary. Dr. Jayalal, your thoughts on combating misinformation at all levels, government, individual, and civil society. Sorry, you are on mute, Dr. Jayalal. Any thoughts on the misinformation, how to combat misinformation that spreads either at the civil society level or the government level? What are the efforts that all of us can do to combat misinformation about the COVID?
That is one of the most important challenge now we are facing, because they do not need to go for the phase 1 trial or phase 2 trial. It can come into the market just like that. There's a lot of misinformation and a lot of things which is even demotivating the people to come for the treatment at appropriate time is going on with we have to do, all the medical associations are taking its pledge to see to that. We have to come forward and propagate the message of the good information, right information to the people. When our medical fraternity or the associations are not doing that, there is every chance that the people who are not really involved and people who do not have a real knowledge on that, they will go on propagating the message. But definitely, if we can come out and openly and counter them and put the right perspective and right idea into the mind of the people, that can definitely do. It has a big challenge in this pandemic, and especially countries like our country, like India, where we have a lot of belief and faith, which is playing a major role in the personal life, and a distress situation and a difficult situation. There is a lot of issues on the faith-based treatment which is coming out. We cannot say it is wrong, or we cannot say it is unscientific or unethical, but people have some faith on that. But only we have to understand in the right sense and explain to them, yeah, is nothing wrong in they follow the faithful faith medicine or the healing message, but more so they have to adopt to the right protective message to overcome this disease. That is only possible with a masking and the vaccination. This is only the scientific evidence we need to propagate at the maximum possible level. I think whenever our India is one country where somebody who is new, somebody who is even from Westerner, if he is saying something, and we tend to believe that much more than what our own people are saying. So that way, it is definitely the scientific input can come from people like Vineeta and your group can to propagate a good message. I think that will go in a long way for us to understand that much more better and accept that in a much more easier than what we are saying to the people in a larger level.
Thank you so much to all panelists. It's such an honor to hear your thoughts. And most of all, thank you for the audience who's engaged. And we apologize for not being able to answer more questions, but please take the conversation to social media after this event. And for a minute, we'll before we finish, we can unmute. You can unmute yourself and say goodbyes to each other. And we will have a post-event blog. Stay tuned for that. And please share your thoughts. Your thoughts are very, very important. Engage with the panelists and each other. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you so much, everybody, for being here. You can unmute, say bye, hello, namaste.
Namaste.
Namaste.